Good evening and welcome. My name is Sophie Hayes. I'm the nurse at Integro Medical Clinics, and I'm here to welcome you to this collaborative webinar discussing cannabis medicines and back pain. This webinar is brought to you by Backcare, a charity providing practical and emotional support to people living with back pain through education, information, advice, and small network of UK-based branches. Backcare helps people who have back pain, whether the cause is through injury, musculoskeletal disorders such as scoliosis, axial SPA, or spina bifida, or as a consequence of another underlying health condition such as multiple sclerosis, Parkinson's disease, and cancer. Visit www.backcare.org.uk for more information. And Integro Medical Clinics, one of the few private clinics able to prescribe cannabis medicines in the UK. Our expert team of doctors value their patients and provide gold standard medical care in this emerging field of medicine. If you would like to get in contact with the team at Integro Clinics, details will be provided at the end of this webinar. This CPD accredited session will be focusing on the practical application of biomedical knowledge behind cannabis medicines and back pain. The discussion will explore the potential benefits of the addition of cannabis medicines into a chronic back pain management regime for this diverse patient group. The healthcare professionals taking part in the event have years of experience between them in complex pain management and expertise in the treatment of back pain for a variety of conditions. Dr. Brian Hammond, PhD, is the Vice President of Backcare Charity and is an accomplished chiropractor and osteopath practicing at the Sutton Chiropractic Clinic. Dr. Hammond is a founding member of the European Council on Chiropractic Education and has previously held roles as Treasurer of British Chiropractor Association, Chairman of the Chiropractic Assessment Board, and Chairman of the X-Ray Standards Committee. Dr. Basil Ahmadi is a consultant in anaesthesia and pain medicine at the Whittington Hospital, where he currently practices, covering both acute and chronic pain management. His special interests are the minimally invasive treatment of problems caused by degenerative spinal diseases, including disc herniation, radiculopathies, and spinal stenosis. Dr. Ahmadi can also be found practicing at Complex Spine Clinic in London and is one of the prescribing consultants at Integro Clinics, where he prescribes cannabis-based medicines for a wide range of pain conditions. Dr. Anthony Ordman is the founder of the highly respected Chronic Pain Clinic at London's Royal Free Hospital. He's one of the UK's most experienced specialists in the treatment of pain. For his contributions to pain medicine, Dr. Ordman was awarded Fellowship of the Royal College of Physicians in 2005, and he is the immediate past president of the Pain Medicine section of the Royal Society of Medicine. Dr. Ordman is also the Honorary Clinical Director of Integro Medical Clinics and has a special interest in the potential benefits of cannabis medicines in the area of pain medicine. It's a real privilege to be on a teaching session such as this one with such accomplished individuals. So thank you very much to our panelists for joining us. Thank you for joining us this evening, the audience. I will be monitoring the chat during the presentation. If you would like to ask one of our panelists a question, put it in the chat and I will be moderating a question and answer session at the end of the presentation. We're going to start with a short presentation from Dr. Hammond on the varied presentations of back pain and some of the non-pharmacological methods that can be employed in the management of this symptom. Brian, we can't hear you.
Is that okay?
Lovely, lovely.
Lovely. Okay. Well, as they've said, I've been asked to present the different types of back pain and the different methods used to treat them. And I've got about 10 minutes, so I'm going to rush through quite a lot of this. First of all, the charity, which is very important and is the only charity, as far as we're aware, in the world that's dedicated to the prevention of back and neck pain. So there are 25 million people in the UK who will have back and neck pain this year. 90% will improve significantly within 3 months, but sometimes not completely, and often there are recurrent attacks. About 2.5 million will be classified as chronic, which means that the pain doesn't go away. And back pain is the single biggest cause of disability and quality days lost in the United Kingdom and indeed the Western world. Now, the NICE guidelines, apart from the pharmacology, normally recommend manipulation, acupuncture and exercise, although acupuncture was removed at the last review, not because it doesn't work, but because it's not cost effective. And these are the nice guidelines initially for treating the non-pharmacological treatments for back pain, both acute and chronic. Now, one thing I always say is that every back pain is unique and generally falls into 3 different categories. There are no 2 back pains that are alike, but we have to put them into categories to understand how to treat them. Now, just one thing for the lay people here, this is what we call a motion segment, and there's basically 3 joints, one at the front here, which is the disc, and 2 at the back here, which are the facet joints. So I'll be talking about those, and basically we call this a 3-joint complex. So back problems generally fall into 3 categories. Something is stuck and not moving, a little bit like getting the knife caught in the knife and fork drawer. When you're trying to close the drawer, it becomes stuck and the knife digs in the woodwork. Something is tight and not moving because muscles have shrunk or ligaments have become shortened, or something is actually loose. It's moving a lot more than it should do. So those are the 3 general categories. Now, when something gets stuck, normally you get a sudden onset of severe pain, aggravated by use and relieved by rest. So an example of this is where people wake up with a stiff neck in the morning and they can't move their neck in one direction, and it's exceedingly painful. And it's a very sudden onset, and it's aggravated by movements in a particular direction. Now, we recognize 2 types of these. One of these is a meniscoid, and I'll explain what that is in a minute. And the other one is a lower cervical disc problem, what we call an internal disc derangement. Now, this is an X-ray through somebody's mouth. And you can actually see the top bone, the atlas, just here. And then we've got the second bone, the axis, just here. Now, this space here is the disc between number 2 and number 3. And the facet joints, the little guide joints, are just here. There's one on the left here. But if you look at this one on the right, you can see that it's being held open. And it's being held open by a little tiny piece of cartilage, about the size of a little fingernail, the end of a little fingernail, the white part, and it gets stuck between this bone and this bone in this space just here. Now, these are very well to manipulation. Normally you only need 1 treatment, and immediately after the treatment, the facet joint drops shut and the spine, which was pushed over to one side, goes more towards the center. So that's an example of something getting stuck in the neck. Here's an example of something getting stuck in the bottom of the neck. And what's happened here is that a piece of disc has got stuck in this joint just here, and the neck is being held bent forwards. So it's very likely that the disc between number 5 and number 6 has got stuck. Here are the little guide joints, which you could see in the previous example. So this is an example of a disc blockage or an acute torticollis. Now, the torticollis goes on to produce irritation to the nerve that comes out of the spine at this level, and these are very, very common. You get severe arm pain, a little bit like having sciatica in the arm. You can have some motor and sensory loss, and this particular patient was scheduled for surgery and came to see me, and it took around 14 manipulations to her neck, and she remained asymptomatic at 5-year follow-up. And I think this is one of the best conditions to respond to manipulation. It's unfortunate there are some professions who contraindicate manipulation to this type of problem. But I think that the prognosis is excellent. Now here we can see a blockage between the fourth bone and the fifth bone. So here the patient is bending to the left and you get a wedge shape to the disc. And here the patient is bending to the right. And here we've got a wedge shape which is open on the left. But this disc here is refusing to close on the right hand side. So again, we manipulate these in order to try and get the disc to close on that side. So we come on to the other variety where something is tight or something is loose. And generally these problems are aggravated by rest and relieved by movement. Here's an example of what we call a sway back. So here we've got the spine on the left, which is normal, and the one on the back sways back, and that creates a lot of pressure on the low back. So you can't manipulate this better. You simply have to give it lots of exercises to do to bring the spine forwards. Here's an example of a dentist who actually didn't have back pain at all, but she had lots of pain between her shoulder blades because she got a short right leg, and when she was standing up, she got severe pain between the shoulder blades, so much so that she couldn't work. And this case was treated with a heel lift. I'm just going to mention this because lots of people have heard of referred pain. This is where the pain travels a long distance from where it actually originates. And a long time ago in 1939, when you could do wicked things like this, this gentleman, Kellgren, introduced 6% salt solution and he injected it into the ligaments. And this is what he found. He found that when you inject here between number 3 and number 4, you actually got pain radiating around here. Oops-a-daisy. And when you injected here, number 5, the pain radiated right the way down the leg. So the pain that you feel isn't necessarily coming from where you think it's coming from. This is an example of where things don't move properly. So here we've got a 15-year-old female who had a very mild whiplash when she was 8 and had been 7 months off of school with neck pain and migraine. When we x-rayed her neck, bending forwards, we found that there was very little movement in the bottom of her neck. This is the x-ray of her bending her neck backwards. And what we do is we superimpose the x-rays like this in order to see what the angular movement is between the bones. When we've measured the angular movement between the bones, then we can determine what's the best manipulative treatment in order to restore normal movement. So here's the x-ray before treatment on the left-hand side, and here's the x-ray after treatment on the right-hand side. And this patient made a full recovery. Here's the x-ray bending forwards on the left-hand side and the x-ray bending forwards on the right-hand side after treatment. And we have perfectly normal movement again. I believe there's a question later on spondylolysis and spondylolisthesis, so I think I might wait and discuss this when and if that question comes up. How can we prevent these things? Well, the important thing is lifestyle changes. We all keep our necks bent over to one side. We nod off to sleep in the armchair. We do lots of things with our necks. Our children, we put in car seats. They fall asleep in the car seat, and when you brake, it gives them a mini whiplash. So we need lifestyle changes to change these. And of course, lifting is a really big killer for low backs. People lift far too heavier weights than they should. One thing I will mention is the seated posture, because seating is absolutely imperative. It's imperative that the squab, which is the part of the seat that you sit on, tilts forwards, not backwards. And a lot of work was done in the 70s, where they measured the the arch of the back in different positions. And you can see A is standing up, P is bending forwards, and just sitting down O is almost the maximum distance that you can actually bend your lumbar spine. So sitting for long periods isn't good for you. And I think that actually sitting nowadays is probably one of the biggest causes of low back and neck pain. And recent research shows that people who sit for too long, more than 5 hours a day, have a shorter life expectancy because they cannot get the blood flowing back up their legs. I'm going to leave surgery to my esteemed colleagues, who I believe are going to introduce some of the surgical procedures, which is discectomy and fusion. And they might even mention disc replacement, which is another alternative surgical procedure. Thanks very much.
Lovely, thank you so very much for that really excellent presentation. Thank you. We're just going to be, as exactly as you said, we'll be moving on to Dr. Al-Mahdi's presentation on clinical interventions commonly available for the management of back pain. So Dr. Al-Mahdi, you should be able to share your screen now. Fantastic.
Hello, everybody. I'm Dr. Al-Mahdi, one of the pain consultants in North London. I'm going to talk briefly about the role of pain clinic in the management of back pain. What are the treatment options and what do we do when we receive those patients? To start with, I need to emphasize that we're going to do an introduction and outline some treatment models and then some examples. But I want to emphasize that pain is a biopsychosocial model. It's not something that can be treated at the tip of the needle. It is not going to be treated with medication only. As we've heard from our esteemed colleague, the physical input and the physiotherapy and manipulation has got a significant role. The social and psychological issues around chronic pain situation has and can play a very significant role in back pain problems. When we treat pain in pain clinic, we need to look at the biological model as it's part of the problem, not the holistic problem. And we'll look at the way the pain travels. As Brian mentioned, the pain may show itself up in the lower limb, in the leg, and the foot, where it originates from somewhere in the spine. And each and every pain goes up to the sensory compartment in the brain and the computer, the motherboard. And we need to try and tackle this pain progression at each and every possible level throughout its path in the nervous system. Now, how do we do that? In the pain clinic setup, we emphasize on self-management approach. So as Brian mentioned, education, explanation, lifestyle changes, the way they sit, as mentioned previously, the physical therapies that can be provided before being referred to pain clinic by the osteopath and physiotherapy team, but the chronic pain physiotherapy input that concentrate on exercise-based treatment as well as the manipulation can have and do have an important role. The psychological intervention sometimes in long-term pain conditions where there is an impact on the overall patient psychological status, and vice versa. The psychological status itself can affect the pain and the pain progression and the pain perception. We always emphasize the importance of other complementary alternative approaches, like acupuncture, that's got a significant role itself. But an overall ethos of pain clinic input is to try and improve the self-management approach and empower the patient to be able to help themselves to the best possible way. And yes, there is a role for the interventional pain medicine, as I'm going to discuss in the coming slides. It can vary from simple trigger point injection to intra-articular injection to nerve blocks according to the pathology. Brian explained the pathologies quite well, the 3 categories, and we can explain them in a different anatomical way. Pain coming from the muscles, pain coming from the joints, pain coming from the discs, and pain coming from the nerves between those kind of joints. And we can target each and every pain according to its specific pathology with one of these many interventions. And we don't have time to talk about all those interventions, but I'm going to touch on a few of them that are applicable to chronic back pain problems in the coming slides. How do they work? Those interventions, sometimes they just break the pain spasm pain maintenance cycle in what we call trigger point injections. They may have, whatever we inject may have an anti-inflammatory action where there's a focus of inflammation that is causing the pain to manifest and persevere. Blocking the sympathetic innervation in situations where the sympathetic innervation is involved in the maintenance of pain. Targeting certain channels where it interferes with the pathway of the conduction of the pain impulse from whatever the diseased area or part of the body is to the brain. Or we can stop specific nerve sensing pain from sensing pain. And if that is confined to a certain compartment, as we're going to see in coming slides, stopping them may be the best option in reducing the pain impulses as part of the multimodal therapy in treating the pain condition. We can talk about electrical modulation of the innervation, which is going to be discussed in a couple of slides at the end. And more of, there is a role in each and every intervention to what we call placebo. Placebo is a bad word when we discuss it in the context of research, but placebo is a wonderful word in the context of sharing the confidence and building a rapport between the physician and the patient, and exploiting this rapport in trying to affect the higher centers in using the internal body ability to control pain is always a friend of the physician. You go to someone and the minute you had a chat with someone, you feel that you're more empowered, more in control, and more able to control your pain. And it affects your kind of self-management approach and pathways. And we, in interacting with patients, in offering whatever intervention, whether physical or even by discussing and empowering, we enrich the ability of the patient to control their pain. And this is the actual placebo effect that we refer to. Now, a couple of examples as time permits. The pain, as Brian mentioned, comes from the joints. And I think in 40% of chronic resistant mechanical lower back pain, or a bit more, depending on which study you follow, the pain comes from those facet joints, the joints that comes in the back of your spine. Each and every 2 vertebrae join themselves in a way of a facet joint similar to the knee joint on each side, as an synovial joint is there. And that's how we move forward and backward and twist, together with the flexibility in the intervertebral disc in the front. And those facet joints, like each and every other joint, enable for osteoarthritis, which means just with time, we lose the cartilage lining in those joints, and that can cause the rubbing of those joints and inflammation, and this is what we call arthritis. Osteoarthritis is not a disease itself, it's just the loss of cartilage lining in each and every joint in the body can be referred to as osteoarthritis. And if you lose the cartilage joining in those joints, then you will get some irritation and inflammation due to the physical rubbing of bone and loss of cushioning. Now, of course, as I mentioned earlier, the needle is not the solution, and we talk about the lifestyle changes, the physical therapies that mentioned. The medicinal therapy, I'll leave it to my esteemed colleague Anthony Oldman, who will talk about the analgesic options in treatment of back pain and pain in general. Even surgical options are there, but with limited success when the pain is confined to the back. The non-surgical interventions, which what I do in plain clinic, can and used to only involve the injection of steroids into those joints, and that's called facet joint injections. So we inject steroid into those joints, and that reduces the inflammation and the irritation into those joints, and that improves pain. However, this was found to be of limited value because it needs to be repeated, and the pain comes back after the effect of the steroids stops. Then we looked at trying to stop the nerve that takes the pain from that particular part of the body and convey it to the central nervous system where you feel your pain. And that's what we call medial branch treatment. To start with, we block this small nerve that functions only to sense pain from those joints. And then eventually we can do what we call radiofrequency treatment to those nerves, where we destruct the surface protein in the nerve and stop it from sensing pain. And there's lots of clinical applications for such an intervention. The facet denervation, the treatment of these medial branches in the back, is the commonest in use, but each and every joint is amenable for such an intervention. It's been used for central pains like trigeminal neuralgia, for chronic radiculopathic pain, peripheral pains. It's the treatment of choice actually in osteoma, which is one of the benign bone tumors, and even liver lesions, metastatic liver lesions, and cardiac arrhythmia can be treated in a similar fashion. It's out of the context of this talk. And that's what we do. We introduce a needle. It's a needle type, injection type treatment. We introduce a needle to where this nerve anatomically is, and we check that we are in the right place, and we apply some electricity that will stop that nerve from sensing pain for long term. And we check anatomically and electronically to make sure that we are in the right site and we're not causing any problem to the patient, and in fact only stopping the sensation from the affected anatomical joint that we've identified. The other example that I just mentioned quickly, as time permits, is called neuromodulation, which is basically an implantation of a device like the pacemaker. And this device goes into the epidural space and lives there permanently and generates some electrical circle to try and emulate the internal body's ability to control pain. Now, when we get pain, our body's got a mechanism to try and stop this pain from progressing. And this is the internal inhibition mechanism of pain. And this is something that we've developed in our body since we've been created, before the introduction of medication and the ability of doctors to inject us. So what we thought we could do, we could try and emulate this effect by implanting some electrical device called the spinal cord stimulator in the spinal cord around in the epidural space around the spinal cord, and try and use this internal mechanism by stimulating it to try and control the pain. And this has been shown to be very successful in resistant pain problem. Its indication has grown with time, and basically this is how it looks. We implant those electrodes into the epidural space where the pain progression goes, and we map according to the type of pain and site of pain to where we implant those electrodes, and using an internal battery like the pacemaker that we implant in people's heart. This battery will generate some electrical current that stimulate this reduction in pain progression into the spinal cord, and that's how we aim to control pain in resistant cases. That's where it lands anatomically, and that's just a scheme that explains how it works in a way. I'm gonna stop here. In a nutshell, in the 15 minutes available to me, I wanted to explain what do we do in pain clinics. We aim to approach the back pain or any pain problem in a multimodal, multidisciplinary approach, because pain is a biopsychosocial, and just concentrating on one facet of the problem won't be helpful. I gave a very quick and very loaded view or overview on interventional pain medicine. It is a growing field, and every year we advance in a way of what we can do, what we can offer. And I just gave an overview on two examples: the radiofrequency treatment for facet joint problem in chronic back pain, and the spinal cord stimulation as a treatment option. As I said, I left the physical treatment and physical approach to my esteemed colleague Brian, and I'm leaving the medicinal options and medicinal treatment to my esteemed colleague Anthony Oldman. And that is the end of my presentation, and I think we will take questions at the end, if I'm correct.
That's correct. Thank you so much, Dr. Almadi, for your presentation. I can see there's lots of people in the chat have questions and are sharing their experiences, so thank you guys for doing that. Exactly as Dr. Almadi said, we will be holding a question and answer session at the end. So speaking of which, so we will now have our final presentation by Dr. Oldman on cannabis medicines and how they can be applied in the cases of back pain. So Dr. Oldman, if you are happy to share your screen, we're ready to do so.
Well, can you see
Fantastic.
my slides? Can you
Lovely,
hear me?
thank you.
Good. Well,
Absolutely.
We'll go on. Hello, my name is Anthony Oldman, and I'm one of the consultants at Integral Medical Clinics. And thank you very much to Backcare and to Brian and to Sophie for inviting me along to speak. So, what is this about cannabis medicines and back pain? And one of the things I want to do is demystify cannabis medicines, show you that they are medicines like other medicines, but I think they're rather special at the same time. My personal journey in pain medicine began there at the Royal Free Hospital in North London, where I set up what is now a big pain medicine clinic. And we practiced conventional medicine with medicines. Here we have amitriptyline tablets, I think, and we have some morphine tablets and gabapentin tablets. And I expect a lot of people here today will be familiar personally with at least some of these medicines, which can often do a lot of good, but sometimes just don't. And like Basil, I've also done my fair share, and I still do, of interventional pain medicine, where we're doing highly technical things to spines and nerves and backs and things to try and reduce pain at its source. And as Basil stressed, we worked very, very much in a multidisciplinary sort of way. So there's the slim, young, good-looking fellow, I don't know who he is. And then we had Shirley, our amazing psychologist, and we had Jane, who was a fantastic physiotherapist, and we all met our patients together and discussed their cases, and the patients met us all together, and it was a very powerful way of trying to help people. And why did we need so many disciplines? Because we, human beings, are complex things. We are bio-psycho-social things. Our human attributes are not only our bodies and how they work, our biology, our minds are enormously powerful things. And there's huge interaction between our mind and our body in both directions. And we fit into society, and we're hugely influenced by society. So the biological bit is the pain, something is hurting. And the psychological bit is the distress and the anxiety and the low mood and our pessimistic thoughts that come from being in this painful situation. And then we're grumpy with our family, and we don't see our friends anymore. We don't go out walking or running, and everything gets physically, mentally worse. And then our body gets worse again. So this biopsychosocial model is very important whenever one's thinking about human beings and pain management, even in a cannabis medicine clinic. Let's talk a little bit more. I think we've seen this already before. This tissue here, it may be a muscle or something that's been injured or burnt or torn, and then nerves take those messages about inflammation or damage into the spinal cord, and a huge amount of processing goes on in the spinal cord. Is this an urgent matter that we need to tell headquarters about? A lot of decision making is here before messages about the sensation go up to the brain where we experience it. Pain doesn't really exist, but we experience it with our brains. And also, if we're in a fantastic mood, then our brain will say, look, ignore the pain, things are going really, really well. If we're about to score the winning goal at Wembley, sorry, this is a bit male-centric, well, it could be women's football, couldn't it? If we're about to score the winning goal and somebody's boot connects with our shin, we don't notice it because our brain's saying, ignore it, we've got more important things to do. But if it's a wet, gloomy, February Thursday afternoon and it's dark and we're standing at the bus stop and it's wet and somebody kicks us in the shin, it hurts like anything because the inhibition isn't working. This is how much our psychology controls our pain, and why we have to think about the well-being of the brain and the sort of mood that it's in. So here's the spinal cord, here are the nerves coming in, here is all this processing going on with hundreds of thousands of nerve cells, neurons, talking to each other, deciding to make the message more urgent or less urgent. It's about pain or it's about a nice thing that's happening, and so on and so on. And if you look at the junctions between these nerves, here are the nerves, there are thousands of nerve chemicals being released to tell the next nerve what's happening. And some of these will make this next nerve more excitable and some will make them less excitable. And all these decisions are being made by complex chemical interactions between the nerve cells. And when a pain has been around for a long time, the nerve cells get even more complicated than they used to be, and even more excitable than they used to be, to our disadvantage, because now the pain gets straight through to the brain and it's very difficult to turn that down again. The other thing we've learned recently is that the tissues around here get inflamed. It's curious, isn't it? If you've damaged your leg, then parts of your spinal cord that can correspond to your leg get inflamed. And that makes the nerves even more irritable and excitable. So now we have an inflamed area of the spinal cord. The brain changes, the actual layout of where things are represented in the brain change in long-term pain. And that can be a problem as well, because it rather ingrains the pain into the person's body and into their brain. And here are the very complicated messages going up to the brain and down to the brain, from the brain, as we've already said. So we are very much biopsychosocial beings because of these complex interactions. We are the mind and the body. So a little bit about how we use conventional pain medicines, as Basil said. I'll talk a little bit about it. They tend to fall into major groups. We're all familiar with taking codeine or dihydrocodeine or morphine, and we all sort of believe as a society that these are the best and strongest medicines, painkillers. And well, they are if you've had an acute injury or you've just had an operation or something. The problem with long-term pain is the body gets used to them very quickly. And this is called tachyphalaxis. And so after about 8 or 10 weeks of taking morphine, they don't work anymore. But you still have all the problems that morphine caused. They make you sleepy, they make you constipated, they take away your energy, and you're stuck on them if you're not careful. More recently came along gabapentin and pregabalin, But just like morphine, they only help about 1 in 4, 1 in 6 long-term nerve pains. But everybody gets the unpleasant side effects, including getting hooked on them. And so many of our patients are turned into what I call zombies. They're sort of not quite with us a lot of the time, and that we're taking more life away from them than we're giving them back by reducing pain. And then we're all used to the anti-inflammatories, the non-steroidals, the aspirins, now it's the ibuprofens and naprox, and they can be very useful. They reduce the inflammation that make nerve endings and the spinal cord so irritable. But they don't always work. They're not good for your stomach or your kidneys. And nothing here is a painkiller. Nothing really kills pain. And they all tend to have bad side effects. Even the more modern antidepressants can make people feel a bit dopey and not quite themselves. And people can get hooked on those as well. So medicines are good and we use them to best advantage, but they're not magic. Another interesting thing to say about many of the medicines we have, including morphine, for example, is that the original molecules that human beings learned to use came from plants. And we're quite familiar with the fact that morphine can be found in the seeds of a poppy plant. Not grown in your back garden here because it's not hot enough, but in warmer climates, you can get morphine and morphine-like substances from the poppy plants. And then maybe a couple of 100 years ago, an astute English physician noticed that there was a substance in foxglove flowers that could strengthen and stabilize a failing heart. And he took the Latin name of these flowers and called his drug Digoxin, which some people are still given today. So there's another example of a phytomedicine, a medicine that comes from plants. Aspirin, which I mentioned a few minutes ago, comes originally from the bark of the willow tree. So another plant-derived medicine. Why on earth am I talking about plants? Well, I'll come to that in a minute. How do drugs work? I hadn't a clue when I went to medical school. It just swallowed it and it worked. Well, that's often true, but how do they work? Well, drugs are like keys that slip into locks or receptors on specific cells. So a morphine molecule will be like a key and it'll slip into a lock or a receptor on a nerve cell in our spinal cord, and it'll reduce the excitability of that nerve cell and it'll reduce pain, for example. And so here are lots of little keys being released by one nerve ending and ending up on the receptors, the locks of the next nerve ending, and it can either lock the next cell and quieten it down, or it can open the next nerve cell and speed it up, depending on where it fits in the equation. Well, so do our opioids work like this way. They land on mu receptors on our spinal cord nerves. And we have our own, the reason that this works is because we have our own substances, endorphins and enkephalins, which maintain the activity of our body, which regulate how our body works. And it's just luck, really, and the ingenuity of our ancestors, which found a plant molecule that was very similar to these and therefore can be used to affect the body, usually in a useful way. Similarly, gabapentin and pregabalin, which are synthetic substances, land on calcium receptors, which have always been there in our body, and they tend to calm excitable nerve cells down. The aspirins, and the more modern versions of that, sit on enzymes called cyclooxygenases, landing on their receptors, and they reduce inflammation. And similarly, the antidepressant medicines can sit into little receptors which then affect the absorption of substances such as noradrenaline. So you're quite expert now, because I've been talking endlessly about this, these transmitter substances, which are the keys, and then receptors on the next cell, which are affected. So, gosh, where is he going with this? This is all very strange. How does this link up with cannabis medicines? Well, you are now familiar with poppies and foxglove and willow trees, and I think you'll recognize the spiky leaves here of a cannabis plant. And whereas we get useful chemicals from these plants, we get the cannabinoids from cannabis plants. And in fact, they come from the flowers. Some are found in the leaves and so on from hemp, but most of the cannabinoids we're interested in come from these little hair cells on the flowers of the cannabis plants, and these are called trichomes. And this is where you find all the phytocannabinoids that we're so interested in. Plant-derived cannabinoids are phytocannabinoids. And they're mostly, the ones we're mostly interested in, the most active ones are probably THC and CBD. We're all familiar with those abbreviations. CBD, this is where my pronunciation might let me down, is cannabidiol, which is plentiful and actually you can buy over the counter in the high street. And it's a very useful drug, although often in the high street you don't quite get enough. And by itself, it's not quite enough to have useful effects, but some people are helped by CBD alone. It doesn't, you're allowed to buy it without a prescription because it doesn't affect the brain and the psyche and so on. And but it does reduce pain. It also helps reduce the anxiety that goes with pain. If your medicines or your pain are making you feel sick, it can reduce feeling sick. And we feel, it's difficult to be quite sure, but we do feel it reduces the inflammation that goes with injury or illness that cause back pain, whether yours is an osteoarthritis back pain or a strain, or due to ankylosing spondylitis or whatever it is, the anti-inflammatory part can be quite useful. And here's the other main cannabinoid, tetrahydrocannabinol, THC. This is the one that can affect your mind, and it can make you hyped or hallucinating or whatever. And that's why it's a strictly controlled prescription medicine. It's a controlled drug. And it's powerfully anti-nociceptive. In other words, it reduces pain sensation and transmission, as well as reducing nausea and so on. So these are the main phytocannabinoids, and they land on these cannabis receptors on the nerve cells, which are really widespread throughout our body, actually. And so why are they widespread throughout our body? Well, any animal that's sophisticated enough to have a spinal cord, and maybe even more primitive animals, maybe even worms and things, use cannabinoids of their own, natural endocannabinoids, to regulate so many aspects of the ways their bodies work, whether it's inflammation, whether it's movement and motor activity, or the tightness of the muscles or whatever. These tend to be regulated in our bodies all the time by our own endocannabinoids. And the two main endocannabinoids that we have in our bodies are known as anandamide and 2-AG. And what sort of things are the endocannabinoids regulating? Memory and learning, the development of your brain and nervous system, your stress and your emotions, temperature regulation, whether you tend to get addicted to things or not, pain sensation, which is very important for us today, your energy levels, your appetite, up or down, your digestion, your movement and fertility, all seem to be controlled by your endocannabinoid system. And there are two main sorts of receptors. There are the Cb1 receptors, which seem to be in our brain and many, many other places, brain and spinal cord, I should say. And the Cb2 receptors probably are important as well, because they very much regulate our immune activity. And when we injure our tissues, or we have inflammation, for example, in various sorts of arthritis or or ankylosing spondylitis, then our immune system's overactive, and that needs a bit of regulation as well. So throughout our pain processing system, there are cannabinoid receptors. I think that's the important message here. And there's this very, very complicated processing. Shall we tell headquarters there's a pain? No, no, it's a nice sensation. This is all fanciful, but this is all of the upping and downing of the messages that are going on with these different receptors and in the spinal cord and in the brain, which are influenced by CBD and THC and so on. The brain is also very much dependent on its endocannabinoid system for upping and downing its activity. I'm sorry about the slides. And the great thing about the cannabinoid medicines is that they really do work in the spine, whereas things like gabapentin don't really work very well in the spine where pain is processed. But they also work in the brain. But the lucky thing is they work in the areas where we perceive pain and where our moods are generated and so on, and where our muscle tensions are regulated, and where we feel fear and where our memory is formed. But they don't work so much in the brainstem where vital functions like breathing and heart control and so on are regulated. So unlike morphine, where you can never quite give enough morphine because you're going to stop somebody breathing, with cannabis medicines, you give more because they're not so dangerous, to put it bluntly. It's very difficult to kill somebody with cannabis. Not that I've ever tried, please believe me that, but they're intrinsically much safer than many of the conventional medicines that we use in pain clinics. And so how now do we put all this together in long-term pain? Well, one of the great names in understanding cannabis medicine really is a journey that's really only been going for about 30 years. We really only understood about the endocannabinoid system for 30 years or so. And it's only just in the last 2 or 3 years in this country that we're beginning to use that knowledge and use the substances available to tackle pain and other conditions in a reasonable way. So one of the great minds, Rousseau, in cannabis medicine, he hypothesized that in our endocannabinoid system, there's a sort of resting level of activity which just about keeps everything in our body just about right for most of the time. But when the system has been very, very stressed by injury or long-term stress or long-term disability because something's snapped or broken or tight or blocked, as Brian was saying, in our spine, then the endocannabinoid system isn't enough, or it gets worn out, or there's not enough chemical or something to keep things on an even keel, and then we start to feel very chronically, very long-term unwell. And I firmly believe, and this isn't my idea, that in some conditions, some painful conditions, migraine, fibromyalgia, back pain, irritable bowel syndrome, that it's our endocannabinoid system that just isn't acting as a homeostatic regulator. It's not regulating our bodies, the balance of our bodies correctly. It's as if the pendulum, which would normally sort of swing here in its balanced position, has been pushed by stress and pain and exhaustion and tiredness over here, and it's stuck here. And it's not going to move unless we bring in some outside cannabinoids from plants, phytocannabinoids, to push the system back to where it should be in a state of balance. And that's where our phytocannabinoids, our plant-based cannabinoids, come into pain medicine. The main substances, as I've said, are the THC and the CBD from cannabis plants, but there are other substances which we at Intergrow take very seriously, the terpenes, which people don't always think about, but they're very important in fine-tuning the actions of cannabis medicines. People who've used cannabis for a while will have their favorite cannabis plant because of the terpene blend in it. And of course, a lot of people with a long-term back pain or any other pain have, for very understandable reasons, turned to cannabis, just buying cannabis and using it really in desperation about what to do. And they'll be familiar that there are different cultivars. They used to be called different strains of cannabis plants. There are the indica ones, which have enough terpenes in them to make you sleepy and relaxed. And then there are the more daytime cannabis plants, which can be useful during the day, which don't sedate you so much. And some people resort to using these different cultivars, different strains of cannabis itself, because of the desperation they feel with their pain or whatever. And here's a bit more of a summary, which we can come back to another time, about what a sativa sort of cannabis plant will do for you. And it doesn't mean you grow up to 20 feet tall, that's the plant, not you. And then the indica plant, which is more sedating and can be useful, particularly when people can't sleep. And here are some of the terpenes, which you'll also find in other plants, giving them the characteristic scents and possibly benefits when we take them. And so we now use those substances from the cannabis flowers, either as flower, and at Integro we're very conscious to know exactly what's in the cannabis medicines we use. Yes, we want to know the THC, and yes, we want to know the CBD content, but we're also very keen to know what the terpene content is, because we're prescribing medicines and we need to know exactly what's in them. But unlike gabapentin or morphine, we're actually prescribing your whole family of substances, and that's how they can tackle so many of the difficulties that you're having with pain, the muscle spasm, the loss of being able to get about, the grumpiness, the poor sleep, and the being fed up and the exhaustion, the lack of appetite, can all be helped by the substances in cannabis medicines. What are we hoping to do for you or for those people in pain with cannabis medicines? Well, we're hoping to reduce the sensation of pain. But it's not only the sensation of pain that people are suffering from. The muscle relaxing properties of cannabis medicines will also relax your muscle spasm, which itself is painful, and allow you to move better. We're pretty sure, as I've said already, that cannabis medicines reduce inflammation, not only at the site of the injury, but in your brain and in your spinal cord. And we know that that inflammation can wind the pain up and make it worse. Cannabis medicines, if we get the balance right, and we often have daytime medicines and nighttime medicines, can improve your sleep duration and also the quality of your sleep, so that you do useful things like storing memory properly when you're asleep from the previous day, that you do dreaming so that your emotions get a chance to be sorted out when you sleep. So with cannabis medicines, as opposed to other medicines, the quality of and the duration of your sleep are improved, so you can face the day better the next day and your pain doesn't have so much impact. Most of us, when we're injured and hurt, are anxious about the future. Cannabis medicines can be used to reduce your anxiety. It can improve your mood and lift your mood if pain is making you feel low and depressed. It can give you your energy back. Cannabis medicines can restore normal activities which are robbed from us when we're in long-term pain. But when we're prescribing cannabis medicines, we expect never to turn somebody into a zombie. We never want to turn them into anything except the person they were before they got pain. And that's something we can claim to do pretty well, that I think you can't do so well with conventional medicines. So just talking about us for a little bit, what is Integro Medical Clinics? How do we integrate all of this into our practice? Well, we're a pain clinic. Actually, we treat other things as well, depression and anxiety and so on. We have different specialists, but most of us are pain specialists. And we can still use conventional pain medicines because that's what we do, and we can still suggest conventional treatments sometimes. We still exercise very much a patient-centered biopsychosocial approach, because that's the only way, in my view, that you can practice good pain medicine. But now we're using specialist cannabis-based medicines whenever we feel it's appropriate. And for most of our patients, this is appropriate. But we stress that we want our patients to try the conventional approaches first. We want them to go to see Brian or one of his colleagues, because physical therapy, if I'm allowed to call it Brian, is terribly, terribly important and can't be bypassed. And we think that some of the pain medicines may be helpful for some people with long-term pain, and that some of Basil's interventions that he talked about may well be helpful for some people with back pain. But if they haven't helped, we feel that we can still hope to help people quite a lot now. We've got enough experience over a reasonable amount of time to feel that when conventional pain approaches aren't helping, it really is worth giving cannabis medicines a try. They're more likely to give you back positive things in life than take away things from you. So, cannabis medicines, how do we use them? Well, we're very lucky we're associated with a really first-class pharmacy which has the very best products available. Many of our patients will take oils, just a few drops of oil under the tongue absorbed into the bloodstream, and they're going all over the body to where those receptors are. And so we have a selection of all sorts of oils available to us. These are extracts of THC and CBD with different proportions and different amount of flavonoids in them, and we'll find the right one for each person and the right dose for each person. Sometimes people need higher doses, particularly those who've tried cannabis already for their pain, and we will supply them with cannabis flower of fairly accurately known contents, THC, CBD, and terpenes. We'll find the right balance for that person and for the time of day that they're going to be using them in. We say, you must never smoke these. In fact, that's not permitted, but you vaporize them with a vaporizer, which heats up a little amount of the flower, and then that's inhaled and it goes into your bloodstream through your lungs. And you can get higher amounts into the bloodstream more quickly in this way. So some people prefer vaporization, especially at night. And we've got this excellent team. Sophie, who's our chairperson today, is really so knowledgeable about the blends of medicines and what to use for what, that we're always asking her for advice, and she gives us good advice. And we have top quality pharmacy advice as well. I'd like to add here, in case there's any doubt, that since in the last 2 or 3 years, prescribed cannabis medicines are fully legal in the United Kingdom. So there's no problem about that. They're not fully licensed medical products yet, for a variety of reasons. One is that we just haven't had time to do the research and to do the studies. But there is an awful lot of experience out there that makes us feel that they can be very effective, and they're really pretty safe things with very low chance of dependency. We prefer not to prescribe to people under 18 because their brains are still developing, and we don't want to affect those unless the medical condition really is very urgent. I know that Sophie's sending me a message. It probably says, hurry up, I'm hurrying up. And we don't want anybody who's about to become pregnant or is breastfeeding to take these medicines, because that could affect the brain of the developing brain of the baby. In fact, we tend not to use these on people under 25 because their nervous systems are still developing. And we sort of a bit careful if there's a fella who's thinking of fathering a child, because it could possibly reduce fertility. So, nearly finished. How would your patient journey in a cannabis clinic work? Well, first of all, you need some information. It's on the website. And if you express an interest, we'll send you even more information so you can be satisfied that you sort of know what you're dealing with. We'd ask you for a lot of paperwork because we want to know everything that's relevant about you for safety. And we'd ask your GP to send us a summary of your records, if you give permission for that, again, so we know everything that we need to know about you for safety, and so that we can send your GP information as well about what we're prescribing, because very occasionally cannabis medicines can interfere with other medicines, such as anticoagulants and things, and the GP needs to know. There'll be even more information exchanged in both directions. And then mysteriously, I haven't quite worked this out yet, most of our patients seem to have a chat with Sophie or Claire, our specialist pharmacist, before they come and chat with me or one of my specialist colleagues, usually by video link. And we have a long consultation, maybe 40 minutes. So we know a lot about you, and you can ask any questions you want before you commit yourself to trying cannabis medicines. We then take your case and discuss it with our colleagues in a multidisciplinary team meeting, because we want to share the responsibility of deciding whether or not to prescribe you cannabis medicines with our colleagues. So you're getting some really good decisions made. We then go into a prescribing huddle with Sophie and Claire and decide what to offer you by the way of the prescription. And you can then get them at home, you can try them, find out what doses suit you, and then we'll be following you up, often within a week, say, how are you getting on? You know, try upping this or downing that. And after about 3 months, with monthly follow-ups, we hope that you're in a steady state with your medicines and you're enjoying your life again. And we also hope that we can begin to reduce your other medicines, which may have zombified you. And in conventional pain clinics, actually, this is not an exaggeration, is called detoxification. So often with the permission of your doctor, the cannabis medicines can replace some of the other medicines, which but maybe not helping you very much. So, Sophie, I've nearly finished, and that's my little run through cannabis medicines. I hope it's been interesting. And if you'd like to know more, please go to our website, integroclinics.com, or you can phone up and have a chat. And if there are any questions about anything specific, there's my email address, and I'll either reply to your question as best I can or pass it on to one of my colleagues who maybe knows more about it. So there we are, and thank you very much.
Lovely, thank you so much, Dr. Orman. And I apologise for the 5-minute warning. I don't think there's really enough time for any of your that we had enough time for any of your presentations. Each of those topics is so in depth and needs so much explanation and discussion that perhaps we'll do it again sometime so we can have another look at them. But if everyone is happy, I'm going to move on to the questions, because we've had a lot of questions for all of the panelists. So I'm just going to start going through them. So we had a question from an anonymous individual. So it was, if I'm finding medical cannabis combined with exercise and stretching is working, is there any requirement for more invasive treatments such as injections, etc.? Dr. Almaldi?
I'll take that one. No. Injections, etc., surgery are just options to try and help with the pain. If the pain is well controlled, if you're getting on with life, then I wouldn't touch any patient in such a situation with a needle. Our aim is to make you functional and make you able to, as I said, self-manage. And if you've achieved this without a needle, then no, I would not attempt any needling. That question answered?
I think that sort of opinion is shared by quite a lot of clinicians, isn't it? That non-invasive would always be the ideal starting place, and then it's only when it gets more and more complex and difficult that we will go for more invasive procedures such as injections. As it will be said, that's fair, Dr. Almaldi. So we've got another question here specifically for Dr. Orman. Do you believe that due to the social connection of treatment, sometimes treatment of chronic pain has to change through someone's lifestyle depending on what is happening? Okay, maybe, excuse me, reword that. I think this lady, Sarah Morgan, is asking about the connection between chronic pain and stresses from external factors in your life. So can your external stresses have an impact on how you experience?
Well, absolutely. As I said before, we are biopsychosocial beings. So whereas in my little guided tour through that triangle, I started with a physical pain. We could equally have started with society, which includes our family and our friends and our spouse and so on. And if somebody is winding us up and our muscles are tighter and we're not sleeping well, then we're much more prone to developing pain and a chronic pain. And that's woven into our English language. You know, we say, oh, that person's a pain in the backside, or, you know, when a problem is solved, we say, well, that's a weight off my shoulders, you know. So yes, even in our language, there's this complex interaction between stress and pain. More than that, in my clinical practice over the years, and I think it's being more and more widely recognized, is that people who've had long-term stresses in their life, particularly in childhood, we now call them adverse childhood effects, they actually set our bodies and our nervous systems up in a precarious way, so that those people are now much more prone, unfortunately, to chronic pain, and I'm thinking of fibromyalgia and all sorts of things, if they've had stressful lives and difficult things to deal with. We're very much biopsychosocial beings.
I think that's a really, really comprehensive answer. Thank you very much, Dr. Ordman. I've got another question, possibly for yourself, possibly for Dr. Ahmadi, from Kerry Cooper here. She says, unfortunately, she has been unable to work as an occupational therapist for 4 years since a disc prolapse and developing chronic nerve pain. Says, I'm now at the stage I'm considering returning part-time. I've just come off of pregabalin, previously was on a huge amount of other medications. And I take CBD 70 milligrams daily, but feel medicinal cannabis could be beneficial. And I don't want to take pharmaceutical medications due to long-term side effects, which I think is a concern that a lot of patients have. So being prescribed medicinal cannabis, would this affect my ability to return to the NHS?
Who's that question for, Sophie?
Oh, it's for you, I think.
Oh, right. There we go. Try and stop me talking again. Well, I'll tell you an anecdote. We did have a clinician who worked in the NHS in our clinic, and she went back to work, and her colleague said, why are you walking normally? Which I thought was rather nice. But this has to be handled very carefully. And one of the things that we discuss in our multidisciplinary team meetings is the work and the safety of work, particularly amongst healthcare workers, drivers, and so on. We aim to minimize side effects from cannabis medicines, and I'm personally more confident that we can do that than with your pregabalin or morphine or whatever, or even tricyclics. So I think every person returning to work has to be reviewed on a very, very individual basis. And I would always want people to share their cannabis medicine usage with their occupational health department and with their employers, because I think openness is terribly, terribly important. And they might even ask one of your colleagues to keep an eye on you for a week, see if she's, doing all right. And the answer probably is yes. And I think you'd be much better at work because you've slept properly and you're not preoccupied by pain and spasm and so on. So the answer is yes. We very much hope that people can return to most jobs. We don't want people driving petrol tankers on cannabis medicines, but I think healthcare work is possible, but it needs to be done carefully, thoughtfully, and on an individual basis. Would you agree with that, Sophie?
No, I completely agree with that. I think that's a really good answer to that question. It is about making, I think a lot of people who haven't experienced chronic pain probably take for granted how cognitively debilitating chronic pain is in itself. And people get prescribed medications to manage that pain, but actually the concern that the medication will be the cause of the problem is often misunderstood. So I think that's really interesting and a really great answer.
And so we do, yeah. We do detoxify people from their morphines and their antidepressants and their pregabalins, and actually I think they're much better off on their cannabis medicines. But then I would say that, wouldn't I? No, it's true.
No, that's an excellent answer anyway. I think, Dr. Hammond, I think this is a question that could be directed at yourself. So this is from Sehar. She says, I've been diagnosed with grade 1 listhesis with spondylolysis of L5 over S1, degenerative spinal changes with disc bulges from L3 to L4, L5 to S1, broad-based L4, L5 disc bulge impinges on both traversing right S1 nerve roots. See how I hope I have got all of that right. I suffer with pain in my leg, no back pain, but I've put up with it now for over a year and it's starting to have a significant effect on my life. My GP and specialists have both said that my only option is an operation, but I suffer from anxiety and have a huge fear of this. Again, I don't think you're alone in that, Sihar. I've done a lot of research that mentions physiotherapy and other interventions might help. Do you think there is anything that I can do to help alleviate my pain that is not surgical? Dr. Hammond.
Can I just show a slide of a spondylolysis and spondylolisthesis? Is that possible?
Yeah, if you think that would help.
So that's this one. She can do share screen. Right. It's not the one. Yeah, I'm sorry, I can't see the. How do I share the screen? Right. I'm not having a lot of luck here sharing my screen. Ah, is that it? Yes, wonderful. I don't know if you can see that. Can you?
I don't think we can actually. Can you give it?
I've got to do share screen, have I? Can you not?
That's right.
Can you not instruct me to share my screen? No.
I think you can do that with the same way you shared your presentation earlier.
Okay, let's just do that. And so share screen, let's try that one.
So Brian, you can click on the green share screen at the bottom, and then you've got to select the screen, which is your presentation, and then that's it.
That's it. There we are.
Yeah.
Up from there. Okay. And this one here. Okay. It's the one before that, I think. Right, well, this is a very complicated condition, spondylolysis and spondylolisthesis, but it's actually very, very common. Spondylolysis exists in about 7% of the entire population. That's where there is a fracture just here, a fatigue fracture between the front of the bone and the back of the bone. We know that most of these fatigue fractures occur between the ages of 5 and 7, because if you take a class of 5-year-olds, none of them have got it. If you take a class of 8-year-olds, about 6% of them have got it, and 7% is the incidence in the general population. Now, as I was saying, you have 3 types of conditions: things that are stuck, things that are tight, and things that are loose. Now, where you actually have the spondylolisthesis, it's loose. And it's very rare to actually get pain from this area, because as you can see, the hole just here that the nerve comes out of actually gets larger. And usually all the pain comes from the segment above, which is this segment here. And here you can see the hole above that is quite large, but this one is actually almost a figure of 8. So this is what we would call a blockage, a discal blockage. And the way to treat this, or the way I've been treating it for the last 40 odd years, is to use manual therapy on this segment only, without trying to treat this segment at all. So it's a little bit like a snooker shot. You know, you want to curve the white ball around the red and hit the pink in the pocket. And it's unfortunate that manual therapy, for a lot of manual therapists, they see that having a spondylolisthesis is actually a contraindication to manipulation. But my experience is that providing you actually treat the right level, it can often respond well. And this particular X-ray was of a nurse who'd had back pain and leg pain on and off about 10 years. And then she developed continuous leg pain, and following manipulation to this 4-5 segment, she no longer has leg pain and comes in for a treatment about once every 2 to 3 months. So I actually think that manual therapy is very good for these conditions where there is something that's stuck above something else that's loose. You just got to make sure you treat the bit that's stuck, not the bit that's loose.
Brilliant. Thank you so much. I think that was really informative, Dr. Hammond. Are you able to take or unshare your screen temporarily?
Right, how do I do that? I'm sure I can stop share. There we are.
Fantastic. Thank you so much. I think we've got time for another couple of questions. Dr. Almaldi, I have one from Harriet here saying she feels very stuck. Essentially, she has had multiple back conditions, including coccydnia and spinal degeneration. I've had 2 workplace injuries, one in 2004, one in 2019, and those incidents are related. I returned to work to save my mental health, which has been successful, but I'm in this dreadful cycle of pain. I've seen many, many doctors, and they offer me conflicting advice and diagnosis. One has offered me an operation to move my coccyx, which is out of place. The others say it's inoperable. The operation carries significant risk and only 65% success rate from what I've read. I'm concerned that if I fail to take action, I will degenerate further, but I'm equally concerned that if I have an operation, I will suffer even more. Do you know where I can find some guidance? So I think there's that understanding that when patients reach the point of seeing people like yourselves as pain consultants, that they will have had multiple opinions and seen multiple professions. So what would your advice be for
Yes. If you go to blacksmith, you will not get a wooden chair. It depends who you consult. If you start your consultation with a surgeon will offer you surgery. And that's the path of, if you've got a back pain, where do you go? Do you start with the non-invasive approach? Do you start with chiropractor, physiotherapy? Then do you go to the spinal surgeon, or do you go to the pain clinic? And that just guides your path to what's next, what intervention you're going to have next. If you come to a carpenter, yes, he will provide you with a wooden chair before the steel one. So in a nutshell, a pain consultant can review such a situation and see if less invasive approaches like injection, sacrococcygeal injection, radiofrequency treatment of the sacrococcygeal joint, ganglion impulse injections. There are some interventions that helps coccydynia before we consider surgery. And yes, surgery is not very successful for coccydynia. It's not unoperable, but the success rate is not high. Manipulation under anesthesia and trying to bring things back to where it belongs under general anesthetic is as far as it gets surgical intervention, in my opinion, that would be successful. But before that, I would myself consider steroid injection and radiofrequency treatment for the sacrococcygeal joint before surgery and before manipulation. And then manipulation under general anesthetic, which can be done, preferably done by a spinal surgeon, but surgical resection has got a reasonably low success rate, I must confess.
No, thank you so much. I think that you probably answered a lot of people's questions that have come up in the chat actually with that answer. Dr. Hammond, I noticed that you had your hand up briefly.
Yes, I just wanted to say that when I was at college in the 1970s, they actually taught us to manipulate the coccyx as part of the course. And indeed, I've been doing that for the last 45 years. We don't do it under anaesthetic. You simply put on a rubber glove You insert your finger into the rectum, you get hold of the coccyx, and then you hold the coccyx with one hand, and then you push the sacrum down with the other hand. And very often there's an audible click. And sometimes we x-ray these to see which way the coccyx has gone, but it's normally always inwards because people fall on their coccyxes off of horses, or the chair's taken away when they go to sit down or something like that. So my advice would be that you had a manipulation without any anaesthetic first from someone who's competent to provide that type of treatment.
Maybe people in the 70s were braver. Now, if I'm approaching someone with a needle, they want general anesthetics. So yes, the idea is the manipulation. If it's achievable without anesthetics, then definitely without anesthetic, if you've got such an experienced chiropractor like Brian.
I think that's really interesting as well. They've had lots of people in the chat sort of discuss, and in the questions themselves that I've asked you, the panelists, that a lot of patients are worried or have anxiety about things like operations or even the needles, and something as the manipulation that you've explained. You know, I admit that I flinched a little bit when you described it. So I think this is the point, and this is why this panel is so fantastic, is that you will be exactly as Dr. Ramadi says, depending on what route you feel might be right for yourself and your condition, alongside advice from your doctor, is the best approach, and it's a good place to start. So thank you. I think I have one more question for Dr. Ordman, which is from Pip, and he says, I've been on amitriptyline and gabapentin for 11 years for facet joint arthrosis and impingement of nerve roots. My GP can't up the doses anymore as I'm already on a very high dose, and my pain is getting worse, especially at night. Is cannabis treatment something that could help? And if so, how would I go about that?
Well, I'm sorry to hear that you have such troublesome nerve pain and that sleep is affected. I think sleep is vital, as we've said. Well, what you have there is mainly nerve pain, and the cannabis medicines are particularly good for quietening down nerve pain. So I would advise, if there's nothing else that can be tried, trying cannabis medicines. Find yourself a good cannabis clinic, one with a good reputation, and by the way, I can recommend one, and come and find out whether cannabis medicines would be good for you. Probably will. Tell us all your medical information, have a consultation with us, and just try the cannabis medicines for a month or two. See how you get on. You're not going to get hooked on them. It's very unlikely. And we may be able to get you off your amitriptyline and your gabapentin, I think you said. Once that's happened, you may get part of your brain back and part of your mind back and have less pain, and you get yourself back because you've come off those other medicines. So yeah, I think it's time for you. Give it a go.
Thank you very much. Thank you very much, guys. It's really brilliant questions and interesting discussion. Guys, I really apologize if we have run out of time to answer your question. If you do have more questions, an email will be going out at the end of this webinar with contact details for myself and at the clinic. So if you do have any more questions, just fire them my way and I will show you if I can answer them for you. Thank you I'm going to bring this session to a close just with some little bits at the end. I'm going to ask each of our panelists, if you wouldn't mind, sort of closing with a takeaway that you would like the audience to take from this particular webinar. So Dr. Hammond, we'll start with you as you started. What would you like the audience's takeaway to be from this particular session?
Well, I think one of the important things is you've got to find the recipe for you. There are lots of therapists out there. Everybody knows somebody who got rid of somebody's pain. As it said by Dr. Almadi, it depends who you go and see. If you want to cross a river and you go and see a bridge builder, they'll build you a bridge. If you go and see a boat builder, they'll build you a boat. And if you go and sell someone who sells swimwear, they'll sell you a swimming costume. There are all ways of getting across the river, providing you get there. That's the important thing. So find what works for you.
I think that's a brilliant takeaway. Thank you so much, Dr. Hammond. Dr. Almadi, takeaway for our audience.
Yes, there are multiple options, and it's a multidisciplinary team approach. Every one of the team can help in a way. There's no one way to, and so each and every person's input is valuable in trying to control the pain, but eventually you need to understand that it's your journey and it's self-management, and these options are there to help you, and you need to take an ownership of managing your pain and act accordingly.
Again, a really brilliant piece of advice. Thank you very much, Dr. Almadi. Dr. Ordman, final takeaways, please.
Well, I'm going to chime in with my esteemed colleagues. It's all about the individual and what works best for that individual. It may be quite a journey, but the sort of medicine that I like to practice, and I've chosen my colleagues carefully, we all practice individual medicine, and even when we're prescribing cannabinoids, we find the individual mix that's right for that person, and then we try and detoxify them from as many other medicines as we can. There we are. I'm a stuck record. I'll shut up now.
No, brilliant. Thank you so much for everyone for joining, for taking part and presenting. Thank you so much. Just a reminder that Backcare is a charity and relies on the generosity of others to support their work. So if you would like to help Backcare help even more people, support the supporters who are living with back pain, please visit their website at www.backcare.org.uk, where there is a donate button on the homepage, and this will link to various payment options. We hope you found these talks interesting. If you would like to find out more about cannabis medicines and whether they can help you, then do get in touch with the team at Integro, either by phone or completing our contact form, both of which are available on our website at www.integroclinics.com. If you didn't catch that, then further details of both those organisations will be in an email sent out to all attendees after the webinar. This event has also been recorded, and we will be available on both the Backcare and Integro Clinics websites. I'm going to say another final thank you to our panellists for presenting and educating us this evening, and thank you to everyone who's attended and got involved in the chat. Keep an eye out for the recording coming available soon. Thank you very much, guys. It's been a real pleasure to take part in this. I'm going to end the session now. Thank you.